begin by talking about the different classes of psychotropic medications. The other thing I want to do here is give you general dosing guidelines. This material tends to be rather dry, so let's dive in. So these are the big medication classes. We have SSRIs, SNRIs, atypical antidepressants, TCAs, MAOIs, anxiolytic, sedative hypnotic, which essentially are like benzos and then other benzo-like drugs, mood stabilizers, typical antipsychotics, atypical antipsychotics, and then different formulations of the antipsychotics, both for acute agitation as well as long-acting injectables for more chronic psychosis and chronic psychotic disorders. The first medication is fluoxetine, and the reason why I made this chart initially was because I remember when I was a third-year medical student just starting my psychiatry rotation, everyone was using the brand names, and I had no idea what anyone was talking about. So that's why I hope this is helpful for you. Fluoxetine or Prozac can be dosed as low as 5 milligrams. So I guess you could say the range is 5 to 80 milligrams. Sometimes the dose for OCD patients can go up to 100 milligrams, even 120. But let's just say it's 5 to 80. And usually for adults, you start at 20. You could start to 10 and 20 milligrams and then increase by 10 to 20 milligrams, let's say every 2 to 4 weeks, if it's having any effect. Again, these are just general guidelines. You should definitely ask a doctor before starting any medication, and I just provide these for reference as they're common in textbooks. Sertraline is dosed from 25 milligrams. It can be dosed even as low as 12.5, but that's pretty rare, up to 200 milligrams. And typically you'll start it at 25 milligrams for like a week and then go up to 50. 50 milligrams is the lowest effective dose. The interesting thing about Zoloft, and we'll talk about each of these medications in turn, is that it actually follows more of a linear dose-response curve. So the higher the dose, the more effective it might be for both depression and anxiety. For Prozac, the depression typically peaks at about 40 milligrams, and then it becomes more helpful with anxiety above 40 milligrams, but it's not going to help depression. So if you're primarily treating depression and you're maxed out on Prozac at 40 milligrams, there's not much clinical utility going higher than that. Paroxetine is dosed similarly to Prozac, 20 milligrams to 80 milligrams. Older medication, so I don't use it very often, but sometimes occasionally use it for like PTSD because it's on label for that, and it tends to be more calming because it has more antihistaminergic and anticholinergic effects. Lexapro or escitalopram, this is dosed from 5 milligrams to 20 milligrams, and typically you'll start it at 10, and then in a month or two, if the patient hasn't responded, then you can go to 20. A nice medicine because it is easy to dose, so you just say start it at 10, typically. Celexa, which is escitalopram, it had a wider dose curve, but then a warning came out which limited its dose curve. It's essentially just double the dose of Lexapro, so 20 milligrams to 40 milligrams, although in the past we used to use higher doses, and typically it'll start it at 20 milligrams. Also kind of more on the calming side, it's the R enantiomer of Lexapro, Lexapro is the S enantiomer. Celexa, which is citalopram, has both the R and the S, so it has both. Luvox, which is fluvoxamine. I don't use this medication as much either. I think it's 10 milligrams, but don't quote me on that. Up to 20 milligrams. Again, don't quote me, please. It's on label for OCD. That's fluvoxamine's purported better effect. Venlafaxine, it's dosed from, this is a weird dose curve, 37.5 milligrams up to about 225 milligrams. You can go up higher, you can go to 275 often. And you started at that 37.5 milligrams, and then you go up to 75. Some texts will say the lowest effective dose is 150. So you typically want to start low and then go slow and get up to about 150 milligrams. Cymbalta, it's dosed from 20 milligrams. It comes in 20 milligram tablets or 30 milligram tablets. It's dosed from 20 to 120 milligrams. Typically, you start it at 30 milligrams, and then after a week, you can actually go up to 60. 60, some texts will say, is the maximum effective dose for pain and both for mood and anxiety. It's often, since medicine is a practical science, it's worth it to at least try to go up to 90 or 120 to see if there's any benefit, as there is some dispute in the literature as to what the highest dose is and the most effective. An incredible medicine both for pain, Cymbalta, both for pain and anxiety. There's a medicine I just realized that I didn't include in here that's another SNRI. It's called Pristiq. I'm trying to remember the generic name, but I can't. But Pristiq is another good SNRI. The difference is that Effexor venlafaxine starts serotonergic and then turns noradrenergic at higher doses, around 150. It begins to have norepinephrine effects. Cymbalta is equally norepinephrine and serotonergic. And then the last medication that again, I don't really have here, it could be Savella, is another name for it, is mostly noradrenergic. So each of these SNRIs is different then, and patients might respond to them differently. Each of the SRIs are also different, and patients might respond to them differently. Remeron or mirtazapine, it's dosed as low as 7.5 milligrams, and then it can go up to 45. I think it might even be able to go up to 60. This is one that I often have to look up. And you can, a good starting, kind of a normal starting dose, it depends on who you ask, but I often will start it just at 15. And then 30 is considered the lowest effective dose for depression or anxiety. So you'll probably want to get it at least up to that. Wellbutrin or bupropion comes in 3 different formulations: IR, which is immediate release; sustained release, which is SR; and then XL, which is extended release. The formulations of these are a little different. Of course, IR has the shortest half-life. Extended XL has a half-life of 24 hours, and then SR has a half-life of 12 hours. Most of the time, we just use XL for once-a-day dosing and for simplicity. And in that case, it would be dosed from 150 milligrams. Some people will even push it up to 450 milligrams, which would be about 3 tablets a day. So that's a normal dose. Trazodone, interesting dose curve. You can even dose it down to 12.5 milligrams. For some anxiety disorders, especially in the elderly population, you'll see it maybe that low. And then you could dose it a couple times, twice a day, or even 3 times a day at that lowest dose. It will go up to 600 milligrams. Anything less than 300 milligrams isn't really going to help as an antidepressant. It's mostly going to be calming, mostly histaminergic effects, and then anything higher than 300 might actually be helping with depression as well, due to more serotonergic effects. The TCAs are just here as listed. These are not as commonly used. Mostly what I see are amitriptyline and nortriptyline. Donepezil, usually you start at like 5 milligrams. You can use it for sleep, and you can go up to 10 or even 20 milligrams, but you want to try to find the lowest effective dose. Nortriptyline and amitriptyline, I always have to look these up, so I'm not even going to put them in. Clomipramine, you can go up to like 100, 150, sometimes even 200 milligrams. Very good medicine for OCD. That's typically when you see it. Nortriptyline and amitriptyline are usually used by neurologists. Very good for pain. Some of the best medications for pain that we have. I think amitriptyline is the best, although sometimes I get them mixed up because they sound so similar. MAOIs, siloligine, tranylcypromine, phenelzine, and isocarboxazid. The one that you'll see a little bit more on tests and stuff is siloligine is MAOB only, while the remaining are both MAOA and MAOB inhibitors, so they're inhibiting both. Siloligine does impact MAOA, I think, at higher doses, but at lower doses it certainly is only MAOB. The other interesting thing about siloligine is it comes in a patch, which gets around some of the GI effects of the medicine, particularly the risk for the tyramine reaction. And so it might help prevent at lower doses in patch formulation that possible side effect with like aged cheese and hypertensive emergency and things like that. The problem is that the patch is often too low of a dose in order to have an antidepressant effect. So eventually you probably would need to push it above that, and then you would just educate the patient regarding the dietary guidelines. Anxiolytic, Buspar, dosed from like about 5 milligrams. It can go, I think, up to like 20 3 times a day. You can dose it up to 3 times TID 3 times a day to 20 milligrams POT 3 times a day. The lowest effective dose is always the best. A lot of patients have problems with 3 times a day dosing, so you may have to dose it twice a day. Hydroxyzine, a lot of different types of dosages here. We could say 10 milligrams. You could even split a 10 milligram in half, up to 100 milligrams a day. This is, again, something you want to dose twice a day or even 3 times a day. It's helpful for anxiety, especially at the beginning when you're starting an SSRI and the patient wants something now. Both buspirone and hydroxyzine are both okay choices. Zolpidem, which is Ambien, dosed from 5 to 10 milligrams a day. Not uncommon to even start lower than that, 2.5 milligrams. Lunesta, dosed from, I think it's 5, 10. It can come in 3 as well. So I think it comes in 3s, 5s, and 10s. Ambien, I think, actually can even go up to 20. The Lunesta tends to kind of be half the therapeutic dose. So if a patient's on like 5 of Ambien and that's effective, then they'll probably only need like 3 of Lunesta. Or 10 of Ambien, they'll only need like 5 of Lunesta. We'll just say 5. Let's say 5 to 10 milligrams. 10 milligrams is a fairly big dose. Restoril or trimazepam, these are now benzos. There's a number of conversions you need to do to convert one to the other. We'll talk about that more during the benzodiazepine section. This section gets a little more confusing. In general, though, I just want to make the point in passing that you don't want to use benzodiazepines for longer than 2 weeks due to their addictive potential and possible neurocognitive impairment essentially immediately, but then possible long-term neurocognitive effects, which the literature goes back and forth in talking about. Lithium, now this medication can be dosed anywhere from 100 milligrams to, I mean, I've had patients on like 3,000. I mean, this is a medication that you're going to really help with. The level will help you out. In acute mania, and it's a little different from maintenance, but we'll just say 0.06 is about the lithium level to 1.2. That would be more for acute mania. You want it really more around 0.08. And you always want to dose once a day lithium in the evening. This is, of course, controversial, whether to do BID or nightly dosing, which one is better for the kidneys. My understanding from what I've read is it's better to do once a day dosing at night. You could start it at 300 if you're outpatient. You could start it at 600. It's totally appropriate to load lithium as well because it does have a very long half-life. So you could also do a weight-based calculation, which if we have time later, we'll also be able to do. For now, we'll just say, let's say it goes from 300 milligrams to, let's just say, conservatively 1,500 milligrams. Again, it can go much higher than this. And you could just start it at 300 milligrams outpatient, get a level, check it again at 600. Especially for elderly patients, you might even want to start lower because of their lipid changes, of course, and their kidney changes. Lithium is excreted unchanged by the kidney. So if you have kidney difficulties, then you do want to adjust the dosage. Valproic acid, this is dosed about from 250 milligrams to, I think I've seen 125 too. I've seen it up to 3,000 milligrams. Comes in two form. bunch of formulations. It comes in an extended release, an ER formulation in the form of Depakote. It comes in Depakote sprinkles. Lithium also comes in a lithium syrup. So if patients have difficulty swallowing, or if they're acute inpatient and they have had something called a REIS, court-ordered medication, then you could put the lithium syrup in milk or in their food or something like that. Same thing with Depakote sprinkles, or there's a Depakine syrup as well. There's also a DR formulation. So Depakote ER has a 24-hour half-life. Depakote DR has a 12-hour half-life. It's common to start a DR formulation. So a common thing that you'll see, let me go back here. A common thing that you'll see is let's say, start 500 milligrams PO twice a day of Depakote DR. You would then get a level. You'd get a level in 2 days after the beginning, because the half-life of the DR is 12 hours. And then once you get a level, your level needs to be between 60 and 100. Anything lower than 60, the Depakote is actually highly albumin bound, and so it becomes difficult for it to have any effect because it's not really coming off the albumin. So you typically want it higher than 60. And then let's say your level's like 80 on Depakote 500. Well, then you can switch it to 1,000 milligrams PO of the ER, which decreases the final number by about 20% because of bioavailability. The ER formulation is only 80% bioavailability. So then your level would go from, let's say, 80 to a little less than 60. So you might want to then boost it up to 12. You might want to switch to like 1250 at that point. Hopefully this made some level of sense. Again, we're going to be covering all this. Gabapentin dosed from 100 milligrams up to 800 3 times a day, 800 4 times a day. I think it's at least 3,200 milligrams. Again, all renally cleared, 8, 16, 24, yeah, 32. Again, it's renally cleared, so you want to have caution and renal impairment. It's not uncommon to start at like 300 day 1, then a couple days later add another 300 milligrams, then a couple days later add another 300 milligrams. So that by day 6 or 7, you're at 300 3 times a day. It is 3 times a day dosing, so that makes it difficult for some patients. And it really only works for pain at levels above like 1,200, even 2,400 milligrams total a day. So for the pain, you need it a little higher. Pregabalin is BID dosing, so twice a day, and it goes from 150 milligrams, I think, up to 900 milligrams. Again, don't quote me on that. And so it's not uncommon to see 300, actually I think it goes up to 1,200, because you can see 600 twice a day, I think. So start low, 150 twice a day, and then you could go to 300 twice a day, and then you could go to 600 twice a day. But double check those numbers. Lamigdal, this is a medication that you want to start low and go very slow, 25 milligrams to 200 milligrams. You also want to do a med check because things can change the Lamigdal or lamotrigine level, and you don't want the Steven Johnson rash, which is often a test question. You're typically at like 25 milligrams for a week, and then you can go up to 50, and then you're at that for another week, and then you can go up to like 100, then you're at that for a week or two, and then you can go up to 125, 150. It's often prudent just to pause for once you get to about 100. That's what I think is about the lowest effective dose. You can pause there for a month or so and before increasing it further. Carbamazepine, this also has a level. It's important to get it because carbamazepine changes its own metabolism, and the level is 0 to 10, and you don't want anything higher to 10. There's kind of an easy mnemonic to remember the levels, which are carbamazepine, valproic acid, and lithium. Is that lithium is 0 to 1, and what you're wanting is something closer to the 1. Depakote is 0 to 100, and you want something closer to 100. And then carbamazepine is 0 to 10, and you want something closer to 10. So 1, 10, and 100. And then if you just remember which number goes to which medication, then that should help out. Oxcarbazepine is more common. It's dosed from 150 milligrams twice a day, so like kind of a starting dose of 300, up to even 600 twice a day. I think you could even go up higher, but at some point you're worried about hyponatremia, which is the most common side effect. Topiramate started typically like around maybe 25 milligrams POBID. I think it goes up to 200 milligrams. Neurologists typically take this medication higher due to seizures. In psychiatry, we typically use lower dosages, which prevents the stuttering and the word-finding difficulties, which happen at those higher doses. It doesn't have to be, I had BID here. You could just do it nightly or daily. Of course, caution with renal stones. There is a little bit of weight loss with it, which patients typically don't mind. Mostly what we use it for in psychiatry is alcohol cravings, where it has decent evidence, in addition to some headaches, some chronic pain, and then some mood lability possibly. Keppra, medication that's only really used by neurology, important in psychiatry because of its behavioral side effects. It's dosed typically kind of like metformin is what I think, 500 BID, 1000 BID. I think I've seen it a little higher than that, but usually it's around that. Again, you can get levels for this, so your treatment is guided by the levels with Keppra. Typical antipsychotics, we have two big high-potency ones that we used. We have some others, but I just listed the ones that we use the most often. Haldol, which is haloperidol, and then fluphenazine. Both of these are now, of course, generic because they were invented in about the 50s. Low-potency thorazine, which is chlorpromazine, the first antipsychotic ever discovered. And that's why it's called low potency, because it required more medication to block all the dopamine, while Haldol required less. So like Haldol comes in dosages of like 0.5 milligrams up to basically infinity. I mean, in delirium, there's been patients that have gone up to like 200 milligrams of this. But a typical dose would be like 5 starting out or 10 for patients that aren't delirious. For delirium, we use small doses like 0.5 twice a day or even smaller. Fluphenazine, it's kind of a weird dose curve. A medication that I personally don't use a lot, but that a lot of people do use. It's just kind of harder to get levels. But both of these are it's helpful to get levels with to help guide your treatment. As compared to the low potency, so high potency Haldol, you go 0.5 to let's say 200. With the low potency, you would be more at 25 milligrams up to hundreds of milligrams, like 500. I think you can even go up to like 1,000. But let's just say I'm just literally pulling a number out of the hat. I would look this up personally if I was doing it, but it's not uncommon to see like 300 a day, like 100 milligrams 3 times a day. You just really want to monitor the QT interval. Mellaril or thyroidazine isn't used because of the irreversible damage that it can do to the retina. So we don't use that anymore. You can use it a little bit with monitoring, so you will see it every now and then, but in general not used. Abilify, dosed from 2 milligrams to 20 milligrams. There's some thought that this follows a U-shaped dose-response curve, where 10 milligrams might be the magic dose. You just want to start it low and go from 2 to 5 to 7.5 or something like that to 10 to prevent akathisia, which is the most common side effect of Abilify. Geodon or ziprasidone, a medication I don't use very much because it's BID dosing. So I would actually look that up. Patients that are on antipsychotics typically have problems with compliance anyways, so it's difficult to get them to take one medication a day. So that's why I often avoid the medicine, because of BID dosing. On tests, you may see that it increases the QT interval more than the other antipsychotics. This has some dispute in the literature. Seroquel is dosed from 12.5 milligrams up to It could even go up to 1,000. We'll just say 800 milligrams. It comes in both an IR and in an extended release formulation. The extended release formulation is just a little more expensive. The other thing is the extended release formulation, since it is longer acting, doesn't have as big of sedative effects, which oftentimes we actually want with quetiapine because it's really good for anxiety. It's actually the best medication that exists for anxiety with an effect size of like 1.5. It's a humongous effect size. It just wasn't approved due to its side effect profile of weight gain and the metabolic effects. But if you're going to dose it for delirium or for anxiety, then you dose it low dose, like 12.5, 3 times a day or 2 times a day. If you're dosing it for psychosis, you're going to have to go above 300. It's not going to be a very effective dose unless you go above 300 for psychosis. And for mania, you typically are around 200 to 300, and depression typically in that range as well. You could try to go to 400, but oftentimes you get diminishing returns. Risperidone dosed from 0.5 to 12 milligrams. It's uncommon to see it any higher than 6 to 8 milligrams, as that typically is the amount that you have 80% dopamine binding. It also comes in the formulation of M-tabs, which are tablets that dissolve underneath your tongue and taste minty, which we'll use oftentimes on the inpatient setting for patients that we're worried about that are cheeking medications. That's why both risperidone and Zydis, both the M-tab risperidone and the Zydis, the olanzapine, are very common inpatient, because if we're worried about patients pretending to take their medication, cheeking, and spitting them out, then we can use these medications. Olanzapine is dosed, and risperidone can be dosed twice a day. A common would be like 2 BID or 3 BID. A common starting dose could be as low as 0.5. Or if a patient is sicker, you could start it at 1 BID. It's kind of up to how ill you feel like the patient is and how fast they need to recover. Having a max dose of 3 BID is often common for risperidone. Olanzapine will be dosed from 2.5 milligrams up to even 40 milligrams. Now, it's very uncommon, and the pharmacist might look at you sideways if you go above 30, but there is pretty decent evidence for doing so. But I would say the real dose would be kind of starting at 5 or 10 nightly because of its sedative effects, and then you can begin to dose daily as well with patients that are very ill. Clozapine, very interesting titration schedule, can go from 25 milligrams up to hundreds. You could say 800, but that's rather high. We'll say 300 milligrams or 400 milligrams. It kind of depends on what you're treating. We can maybe talk about that in a whole separate lecture. Clozapine would need a whole separate lecture. You're going to increase by 12.5 or 20. Really, you want to start it at 12.5 on day 1. And then day 2 or 3, you can go up to 25. And then on day 5, you can go up to 50. And then you can keep going up by 25 milligrams from there about every other day, every third day. It depends on how aggressive you want to be and how worried about side effects you are. IM formulations are helpful for agitation. So we have Zyprexa. This can be IM or IV. Haldol can be IM or IV. With Haldol, any IM injection is twice the oral dose. So 2 milligrams oral of Haldol is about equal to 2 milligrams IM is about equal to 5 milligrams oral of the Haldol. So this 5 milligrams IM is actually about 10 milligrams oral. So you're giving them a much bigger dose. Ativan IM, you can mix that with Haldol. Don't ever mix Ativan with Zyprexa because there's a possible fatal respiratory depression that can happen. So it needs monitoring. They'll sometimes do it in the emergency room, but they're in the emergency room. This is what they do. If the patient stops breathing, it can actually help them. Otherwise, I would advise against it. Benadryl 50, not uncommon. Geodon 10 comes in that kind of formulation. These are the long-acting, Invega Sustenna, which is just paliperidone, which is a metabolite of risperidone. Comes in typical as 234 milligrams. and then 5 days later, it could be anywhere from 5 days to like a week later, you do 156 milligrams, and then you can actually stop the oral risperidone at that time. And then they would either get monthly 234, monthly 234, or 156 injections. I've seen patients decompensate and get Invega 234 milligrams every 2 weeks. If a patient needs it, that's what they need. Haldol decanate, essentially there's a formula 10 times the oral, 10 to 20 times the oral dose will be how much you load it with. A patient with Haldol decanate, and you'll load them at an interval of like every 2 weeks. We'll have to do a whole separate lecture on this. But right now, let's say the patient is stable on 10 milligrams oral Haldol. They would need 100 to 200 eventually monthly or bi-weekly injections of Haldol every other week injection of Haldol in order to meet that. Fluoxetine, the oral formulation, doesn't reliably convert to the IM formulation, so that makes it difficult. So you'll have to use levels in order to guide your treatment. Abilify Maintaina comes in 100s, and you can drop the oral after the second injection. So you'll have one injection of the Abilify, and then at a month you'll have the next one. So the patient does have to stay on the oral medication for a little bit longer there. Zyprexa Relpreve, not used very frequently now because there is a 1 to 2% chance every time you get the injection of cardiorespiratory collapse, coma essentially, and then you stop breathing. So because of that, if this patient was going to be on this antipsychotic for a long time in this injection, if they got 100 injections, there's like a one-time injection that they're going to have this happen. So because of that, we just don't routinely use it. You'd have to go to a specialty clinic, and they have to monitor you 2 hours after the injection. Note that on this, there's no stimulants. That'll require a totally separate talk. No alpha agonists like guanfacine, or clonidine, or prazosin, or any of those medications, so we'll have to go over those separately. No opiates, no of these quasi-stimulants like atomoxetine and modafinil, these VMAT inhibitors, and no methylphenidates or things like that, so or Adderall. So I hope this was helpful, and we will now go over each of these in turn. This is now going to be our syllabus. We're going to cover SSRIs next, and then SNRIs, and then atypicals, and then we'll continue from there.